Good day. I'm delighted to be here and give my thanks to Senor Barbosa and the Portuguese Foundation for inviting me to speak with you. This talk is recorded in advance, but at the end, we'll have a chance to have a live back and forth with questions. Today, I'm talking about neuropsychiatric illness in adolescence and adulthood in Phelan-McDermid. And it's a where are we now talk because our knowledge continues to change. In terms of disclosures, I have no financial conflicts of interest to declare, but I do want to say that much of what I have learned has come from my own child's struggle with neuropsychiatric illness and our search to understand this and support her, and her story will be woven into today's presentation. All of the work has been made possible with support from the United States PMS Foundation and the dedication of many clinicians and researchers, some of them here today. Here are the big questions I plan to talk about today. First of all, do we know how common psychiatric illness is in Phelan-McDermid? What does it look like when it begins? Are there things that provoke or trigger it? Is there anything we can do to prevent it? And what resources are there for our families? And we'll rely today a lot on video to demonstrate some of the things we're talking about. So it's important to remember that most of the people diagnosed with Phelan-McDermid are still quite young because of the evolution of modern genetic testing. And so the group of people who are diagnosed with psychiatric illness may not be fully representative, and it's going to take a number of years for us to know. How do we know what we know? Well, most studies of psychiatric illness in Phelan-McDermid are of people who are already psychiatrically ill, so it's a select population. And while this helps us to describe patterns of illness in detail, we can't tell what proportion of people or which individuals who have Phelan-McDermid may be more likely to develop psychiatric illness. A lot of what we know has come from a few research studies and from conversations with affected families. We also have the expert consultation team called the Neuropsychiatric Consultation Group, which has done in-depth consultations on 74 cases to date. There's the natural history study based in the US and the US Foundation Data Hub. How common is it? Again, we don't know because we don't know what the denominator is, but we now have a group of over 200 PMS families whose individuals are dealing with serious psychiatric illness who are connected through English-speaking social media. There are clearly many more around the world. These families amount to roughly 10% of all individuals diagnosed with Phelan-McDermid who are at least age 10 or older. Now, when you think about making a psychiatric diagnosis in Phelan-McDermid, it's important to remember that some of the symptoms that would otherwise be counted as symptoms of illness may be longstanding in people with Phelan-McDermid. In fact, they may just be part of the profile. And I've listed here some of the things that people commonly report in individuals with Phelan-McDermid that should probably not be counted towards a psychiatric diagnosis unless they worsen over time. It's important, therefore, to put behavior in context, and we parents can help doctors make accurate diagnosis by really being clear about which symptoms and behaviors are new or much worse, and which are part of how the child or adult always was. And in doing this, videos and behavior logs are incredibly important. So encourage people to take baseline videos of your child's typical behavior, way of communicating, way of moving, hand skills and self-care skills, and also of the things they love to do that give them pleasure. And in parallel, keep a log of sleep patterns and bowel habits and any behaviors that concern you. Behavior changes can certainly be set off by pain from medical causes. This list highlights the role of GI tract intestinal abnormalities in making people miserable. But there's also teeth and headache and menstrual pain, urinary tract problems, seizures, and injuries, since our patients don't always respond immediately to pain, and so we may not know when they've broken or sprained something. What may trigger psychiatric problems in Phelan-McDermid? They tend to start around puberty, probably due to shifts in hormones, but they can start after really any stressor, such as a medical illness or a surgery, or when services and supports change, or at times of family transitions and loss. They can also begin after being exposed to certain kinds of medications, among them antidepressants, antipsychotics, and some anesthetic agents that are related to antipsychotics. Does the type of genetic difference affect the odds? Maybe. And we can say that psychiatric illness is reported across all forms of Phelan-McDermid, but it appears to be diagnosed more often in people who either have SHANK3 variants or have smaller terminal deletions than it is diagnosed in people with larger terminal deletions and rings. And the why of that is complicated. What kinds of psychiatric problems do we see? Pretty much everything. We see anxiety and obsessive compulsive behavior, mood disorders such as depression or mania, that is bipolar disorder, aggression or self-injury, psychotic disorders, catatonia. And you'll notice I put regression in brackets because I don't think of that as really a psychiatric disorder. How do we recognize some of these states in children like ours? They often start slowly. And so you're a month or two down the line when you start saying to yourself, wait a minute, what's happening here? In this next section, we will review videos of patients experiencing some of these different psychiatric conditions. These videos have been shared very generously by families in the hope that they will be useful to others. So what does mania look like? Mania involves a spell of days to weeks, or sometimes even months, during which a person needs much less sleep than is normal for them. And even though they're not sleeping, doesn't seem tired. In fact, the manic state is characterized by high energy, increased movement, more vocalization, louder or faster talk. The person might be excited, silly, giddy, bossy, or cranky, irritable. They may do new impulsive or dangerous things, which can include sexual behaviors, taking off clothes, running away, climbing unsafely in ways that they didn't do prior to the illness. And they may have new intense repeating of behaviors or even projects, such as giving things away. This is a child at the beginning of a manic episode. This is not typical for behavior for him when he was well.
It's recording.
Hey, calm down. Calm. Oh, we're good. Calm down, please.
You want to control the forearm.
Stop. Stop.
And here's an older young man in a manic episode that shows you some of the loud, repetitive, sort of driven qualities. He doesn't really look like he's enjoying what he's doing, but he can't stop.
By the way, you have to touch some again. You have to touch some again. You have to touch a monkey, mommy.
I can't right now, Bo. Maybe you could relax a little.
By the way, monkey, you have to get that monkey.
And this young man demonstrates the jolly, almost contagiously happy mood and impulsive behavior that we call giddiness.
Oh, check your pants. Check Grandpa's pants. Oh boy, check Grandpa's pants.
So what does depression look like? I think most of us know what depression looks like in neurotypical people. And it looks pretty much the same with developmental variants in people with Phelan-McDermid. A spell of days to weeks or months during which a person loses interest in activities or people that they used to enjoy. They have sleep disruption and look tired. They move slowly. They may seem lifeless and lie around all day. They can be prominently sad or fearful or irritable or negative. They're going to have a change in their interest in food and maybe less able or willing to take care of themselves. Anxiety disorders and obsessive compulsive disorder can be hard to recognize in people with intellectual disability or autism if they can't use language well to let us know what they're feeling or thinking. And so we have to rely on observation. And also repetitive behaviors and obsessions with favored objects and activities are pretty common in people with PMS at baseline. So it's really important to distinguish a change in that sort of thing from the person's typical presentation. Signs of anxiety might be refusing to leave the house, go places, or see people they used to enjoy, new fears, increased clinging to caregivers, irritability, trouble settling down to sleep, agitated behavior with attempts to escape. Some parents will describe frantic grabbing. That's not really aggression, it's panic, and they're trying to hold on or sometimes actually to climb onto their caregivers. And overall, physical signs of fear from adrenaline overload, such as restlessness, diarrhea, rapid heart rate, shakiness, or pallor, looking pale. What does OCD look like? Well, in our kids, it's a new or much intensified need to do certain things. And the things can be physical acts or they can be mental acts. So you can see people scattering, emptying closets, emptying drawers, or piling things up or moving things from one place to another. They can pick at their skin or their hair, their clothes, at furniture, at bits of fluff on the floor. They can have repeated questions, again, that are not typical for them, looking for reassurance. And they often become frustrated and lash out if someone gets in the way of them doing the things they are feeling they absolutely have to do. Here at age 16, you see our daughter who suddenly overnight developed an all-encompassing fear that something bad had happened or was going to happen to our family's cat. She needed to be within a few feet of the cat, even at night. They had to sleep in the same room. And if we left the house, she was terrified about the cat. We began to wonder if this might be the thing called PANS or PANDAS. In this first video, you'll see her watching the cat, and even while she's watching her, she's asking if the cat is all right. And in the second video, you see her distress and continued questioning when we're away from the cat. Although you can't probably hear her, she's saying, is she all right? What do you think?
That's not real. Tell me what you know.
And here she's saying they took my cat away.
They did not take your cat away. Why not? Because that's not a real thing. But they did. I saw them do it. No, you didn't. That's a worry. Do you want to give me that worry? Give me that worry. Give me all that worry. Come on.
So this continued for 3 months, and all the adjustments of psychiatric medications had not helped at all. So she was admitted to hospital. She had an extensive medical workup, really didn't show anything in particular. The hospital team agreed that whatever it was, she had become suddenly and severely ill with something that resembled an autoimmune brain disorder, such as autoimmune encephalitis. And as a sort of a, what harm can it do? Let's try it. She was treated with intravenous immunoglobulin and azithromycin, which is an antibiotic, and got better, and within weeks had returned to her normal self. So what does psychosis look like? Psychosis involves hallucinations, so hearing or seeing other things that others can't see or hear, which, some people won't be able to tell you they're having that experience, but you can see them watching something that you can't see, or they'll be interacting and talking to someone you can't see. Delusions are believing things that are not real. Disorientation can happen with new confusion about people and places and times. Bizarre behavior can happen. So things like grimacing or hiding, crawling under furniture, or running themselves into a wall again and again. And you can see deteriorating function in thinking, relationships, and self-care. Now, these symptoms are considered typical of thought disorders such as schizophrenia or schizoaffective disorder. But in fact, in our population, they seem to usually occur during mood episodes such as severe depression or mania, and to go away in between such episodes. Another behavior that people will describe as part of an emerging psychiatric problem is new aggression that isn't typical of the individual. So some children with PMS will pull hair or hit or bite at baseline because they enjoy the reaction, or to convey their frustration, or as a form of communication and connection. And that's really a separate issue, though an important one. Aggression can also appear during mania or catatonia. It can be severe, it can be purposeful with the intent to hurt, but it can also be kind of incidental when the individual is frustrated or under a compulsion. Each of these different forms has different meanings and treatment. Here's a young man who's a really sweet and lovely guy when he's well. During a recent manic episode, in this first one, he's trying to get out of the house, and his big brother is calmly not letting him.
Hi. 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 You're gonna spill the drink on you. You're gonna spill the drink on you. Yep, pull harder. Yep. Can I have that?
And in the second one, suddenly attacks his little brother, something he's never done before. Now, during this time, he had been being treated with increasing doses of Seroquel, quetiapine. And when that was removed and tapered off, he came back to his usual self. And this is what his usual self.
This one over here. Hey, Jared, what are you doing? What are you doing? Jared, come over here and water this plant, honey. How about this one over here?
So this brings us to catatonia. Now, in general, catatonia is quite a rare phenomenon. It's a disturbance of movement and of behavior that can occur in a range of psychiatric and medical conditions. It is known to be more common in people with neurodevelopmental disorders, particularly autism. But interviews with PMS parents of individuals who had psychiatric problems suggest that catatonia is much more common in those with Phelan-McDermid and psychiatric illness than in others, and that the diagnosis is often missed, which is a big worry, and is why I'm going to devote a certain amount of time here to showing that. There's several types of catatonia. They have a wealth of names. The most common one is called akinetic or stuporous, and it involves slowing down, becoming stuck, being unresponsive, no longer speaking or vocalizing. There's a hyperkinetic, hypermotoric, excited catatonia, which looks a lot like mania on steroids. So constant movement, the person is driven and they can't stop. You may see repeating of sounds or motions. You can have an alternating, fluctuating catatonia, which goes back suddenly between these two types. And then there's a complication called neuroleptic malignant syndrome because it is often triggered by antipsychotics, which are also called neuroleptic. And it is a complication which can cause fever, heart rate and blood pressure going up and down, muscle breakdown that leads to kidney damage, and it can require care in an intensive care unit. Trouble advancing my slide here. Antipsychotic medications can trigger catatonia. Antipsychotics are powerful medications. They have notable side effects, both short-term and long-term. Many are approved for irritability in children with autism, and they are increasingly used as the first interventions for a wide range of complaints, including psychotic disorders, which is what they were designed for, as mood stabilizers in bipolar disorder, to treat severe anxiety, to treat agitation, aggression, or self-injury, and to help people sleep. They appear to be tolerated and helpful in some of the younger children with Phelan-McDermid, but they should be used with caution, especially after puberty or if there are already mood problems due to the risk of triggering catatonia. Now, I wanted to describe some of catatonia's unusual symptoms, and we will look at videos of these. Getting stuck in odd postures, changes in the holding angle of the body, arms or legs, difficulty crossing over visual boundaries such as thresholds or the transition from carpet to plain floor or in and out of cars or up and down stairs. Difficulty with ordinary body transitions such as approaching a chair or sofa, turning around and sitting down. It's just a lot of automatic movement patterns can get disrupted. A change in an ability to manage saliva or to handle food in the mouth, which can lead to choking risk. Refusal to eat or drink. Difficulties with releasing urine, which is called acute urinary retention. Odd fluctuating changes in skin color, bright red patches or hands that turn purple or white as if the person had been outside on a very cold day, but they haven't, and new repeating gestures or speech. Here's an example of posturing in a young man with catatonia.
Hi, Hayden. What you doing?
You talking about your movies?
Doing a. Hi, Hayden.
And here's somebody who's stuck in an awkward, uncomfortable posture. Notice that she has a sort of fearful look on her face.
Emily? You don't have to scroll.
And this
You
next
might have to
one,
scroll.
I'm sorry. This next one is verbal repeating in our child. This is not something she'd ever done before. Notice that it's sort of like a broken record. Heavens.
You don't have to scroll. We might have to scroll. We might have to scroll in a little cage. We might have to scroll in a little cage. We might have a little squirrel in the cage, and you might get to hold it. You might get.
So catatonia does appear to be more common in Phelan-McDermott, and we're going to look at what it looks like in several different people. This first one is a 30-year-old young woman. Here she is at baseline dancing with her little cousin. And she was hospitalized for a bout of mania with agitation. This was during COVID, so her family was not able to visit her, but she was treated with 2 antipsychotics at once. And while on the psych ward, she fell and hit her head, and later that same day vomited and appeared to choke on her vomit and was sent to the ICU for most of a week. She was then discharged home, mute, staring, and stiff. It took 4 people to escort her to the car to go home. 2 days later, her family brought her to a different hospital because she couldn't walk or eat. And she remained staring and stiff in this second hospital for over a month. This was her state, and it didn't change. So the team at the second hospital thought she'd had a brain injury, either from the fall or from vomiting and aspirating, despite the fact that her brain imaging showed no changes. But they advised her family not to expect her to recover, and they recommended she be placed in a long-term nursing home. Her family, through our foundation, knew about the possibility of catatonia, and they asked that that be treated. And she was treated with lorazepam, which is the first-line drug, but the increases were slow, and the hospital wasn't comfortable increasing as fully as they should have. So eventually she was treated with ECT, electroconvulsive therapy, which is remarkably effective in catatonia, and she got better. And so here she is. She's been stable for about 3 years. This is shortly after she finished her ECT treatments. She hasn't required any further treatment. This is a different Sarah who developed manic spells with hallucinations at age 13. At that time, she was given risperidone, developed muscle stiffness, and stopped eating, and had to be hospitalized to be fed by tube. Risperidone was stopped, and she went home, and then her new provider started her on Abilify, which seemed to work okay for a bit, but then she developed these changes in walking.
Why don't you stand up straight? Now, doesn't that feel a little better? Can you hold your head up? Why don't you stand up?
And then she stopped eating again and was admitted to the hospital, and once again needed ICU care with a feeding tube for nutrition and to protect from aspiration. This time it was clearly diagnosed as catatonia. Ativan and even a single dose of intravenous immunoglobulin were tried, but were not helpful. they decided to try ECT. Here she is before the ECT. Notice her arms, please.
Can you swing your feet around? Yeah, we'll get your glasses. All right, here you go. Keep going. There's your right one. Can you swing? Good job. All right, let me scoot. Ready? All right, get your feet straight.
And here she is the day after her first ECT treatment. Again, notice her arms. So Sarah had an excellent response to ECT. She got physiotherapy and occupational therapy to restore her smoothness with walking and feeding, and she went home. This video was taken about a year later when she received her next belt in karate. She has since been stable for 8 years. She gets maintenance ECT treatments every 8 to 10 weeks, or if she starts to look manic. Same child.
Yay, Sarah!
This is a 10-year-old named Ibby who is shown first at her baseline, and then when she developed very severe difficulties with manic spells, new aggression, and self-injury. As you'll see, she was given risperidone, which initially may have helped, but then caused a severe reaction. Here she is at baseline.
Amy, who you go walking with today? You've got Archie walking with you. And a whole lot of people. Amy.
Sorry, the difficulty. This is her during a manic spell. It will be.
Hey. Amy. Imogen, stop attacking.
Come on, let's put your hoodie on. Ready? I'm in. Okay. Do you need help to do it up? Do you need help?
So this is her reaction to the risperidone. She became stiff, locked in, and very hot. She was admitted to the hospital, unable to move. You can see that she has a bright red face. She had fever, and her heart rate and blood pressure were going up and down. This was probably neuroleptic malignant syndrome. Risperidone was stopped, and a benzodiazepine diazepam was started, and she recovered. And here she is this year. She improved off risperidone. She's now on lorazepam and lamotrigine. She's just finishing a final taper off Abilify. She likes chasing kangaroos.
Can you see some kangaroos? Where are they? Over here? You gonna go find these kangaroos? Go on, you go find them.
So this brings us to excited or hyperkinetic catatonia. Many doctors will never have heard of this form. Often begins during mania, and there's a lot of overlap in symptoms. You look for intense restlessness, new oppositional behavior that's not typical for the person, unclear speech, trouble managing saliva, holding food in the mouth, stuffing the mouth without chewing or swallowing, new repeating, and you can see confusion and disorientation. This is Mikey, who's 28. Here he is at baseline. And next you'll see him in the grips of excited catatonia.
We'll go to 4. I don't know. The last few days, it's been intense with this energy. Slash, I don't know. It's starting to look a little more anxiety related, but again, we know this is a process. So I just take a video for reference. Today's August 7th. On Monday, we'll go to 4.
Then this is what he looks like when he reaches an effective dose of lorazepam. In his case, it was 15 milligrams per day divided 3.
Hey, today is October 2nd. Michael, say hi. Just taking a video of Michael today. He's on the 5 milligram Ativan 3 times a day. He's doing much better on this dose.
So this is our daughter. She had a severe manic episode with new symptoms, which turned out to be catatonia. She also had her first seizure, which was quite long. And after 3 days in hospital for a battery of tests, she was given IV lorazepam and was completely back to her normal self in 30 minutes. So I'm going to show you before and after lorazepam. And just note that when the lorazepam wore off, about 4 hours later, all of the symptoms returned. So we had a long process to figure out her optimal dose and restore her well-being.
I think Jojo forget by now. I think Jojo would forget by now. Didn't Jojo forget about it now?
So she's bright red.
I love Julia.
She's repeating.
I love Julia.
And here she is 30 minutes after the lorazepam.
Change some blood, okay? It's gonna hurt a little bit. It's gonna hurt a little. It's gonna hurt a little bit.
Unfortunately, there's another video hiding here and running in the background. She was given a new diagnosis of presumed seronegative autoimmune encephalitis, which just means it looks like autoimmune encephalitis, but we can't find any laboratory evidence of it. And she began receiving intravenous immunoglobulin every month, along with low-dose lorazepam and mood stabilizers and oral contraceptives. She went 4 years without another major episode of any kind and has had only a handful of brief episodes since then. Here she is this winter, helping with the snow.
To go inside and her lunch sometimes. I don't know quite what happened. I wonder when I don't know about it, so happy lunch yet. But something.
Okay, well.
It looks very good.
What?
Calling me had leftover, Mom. Maybe something that had leftover, Mom. Okay?
Is that left hand gonna help at all? There we go.
I have to go inside and her.
So, regression. Regression is a great fear for all of us with kids with Phelan-McDermid. There's a bump of skill loss in early childhood. There seems to be perhaps another peak around adolescence. I want to highlight here that it's really important to note whether the loss of skills comes and goes with episodes of medical or psychiatric illness, or whether it continues for months in between episodes of illness. And it's also important to remember that some of the psychiatric drugs that are used in our kids can cause these deficits. What do we know about regression in childhood? It's reported in many small studies and case reports. Ryerson and colleagues evaluated 42 Phelan-McDermid patients, most of them under age 18. Somewhat less than half of them had experienced regression. Of those, about a third in toddler years and 2/3 between about 2.5 and 5. Most reported loss of motor and self-help skills, and 40% of those who had had regression regained their lost skills. What do we know about regression in adulthood? We don't know much. There's very little research on this question. We're working on it. Parents of some older individuals report that they lost almost all of their skills in their 40s, 50s, and 60s. Those parents describe loss of skills frequently that has followed infectious illnesses that triggered bouts of psychiatric illness. And we don't know how common this is, because the presence of the psychiatric illness or of the dramatic loss of skills is probably what led to these individuals getting modern testing and being diagnosed. So it's quite possible that there are many older people with PMS who have not had these crises, who have not been diagnosed. Regression clearly is associated with psychiatric illness in Phelan-McDermid. In our study of 38 people, about 2/3 experienced loss of skills after the onset of psychiatric illness. About half of the ones who lost skills regained their skills when their mental health stabilized, particularly if they received rehab services. And we can't yet predict what this will look like with time and supportive treatment. While it's clear that some teens and adults with Phelan-McDermid do lose skills, do regress, it, I think, is essential not to accept all skill loss as PMS regression. And why is that? Because untreated chronic catatonia and side effects of medication can look like regression. So I want to point out this to me, very moving story of recovery. This is a young man named Chris. He's now in his early 40s. In his teenage years, he was talkative, social, athletic. He had moderate intellectual disability, but could be quite independent. He could come home from high school, let himself into the house using a keypad, make himself a snack, and safely be left alone at home for several hours. Here he is when he was well. And in his 20s, he moved into a group home. And while he was there, he began to have episodes of irritability and aggression, which were treated with antipsychotics. Over the next decade and more, he lost many skills. He lost his continence, no longer used the toilet. He lost many motor skills. He lost almost all of his speech. He lost many self-care skills, and he didn't seem to remember people or the past. And these changes were attributed to PMS regression. Here's Chris during this phase of his life. Chris's parents learned about the possibility of catatonia, and when he was 40, they asked his psychiatrist to try lorazepam. And it was started, but it was increased very slowly, which is a problem because the system habituates. Also, the nurse in charge of his residence, his group home, refused to allow an increase beyond a total daily dose of 8 milligrams. So he had only modest improvements in function. And then about a year into this slow trial of lorazepam, he stopped eating and drinking, and staff couldn't get any meds into him. He lapsed into a stuporous state and was taken to the emergency room where the team thought he might have had a stroke. He was pretty much locked in.
Okay, we're gonna move your head back a little bit.
Couldn't move, wasn't speaking. So his catatonia got better when lorazepam reached 20 milligrams a day, but it took about a month to get him there. And during that month, he lost a great deal of weight, had to have a G tube placed for nutrition, and developed contractures in his arms and legs. He spent almost 3 months in hospital and rehab and was then abruptly discharged, and his group home refused to take him back because he was on a higher dose of lorazepam than they were comfortable with. So he was discharged into his parents' care. And at home, on this high dose of lorazepam, he steadily improved. He regained almost all the skills that had been thought to be lost to regression. He now walks easily and independently. He speaks in full sentences. He remembers the past. He feeds himself. He sings, jokes, and laughs. He enjoys watching sports, and he's regained his ability to use the toilet almost all the time. His group home saw this, and to their credit, they realized the treatment was working and they took him back. Here he is with his dad more recently on about the 1-year anniversary of his catatonic crisis. They're having a little debate about the day of the month.
Is this 17, 18, 19, today? Is this 17, 18, 19? Oh, wait a minute. Let me look. It is 21. I made a mistake. So, no. Where is it? What month are we in? March? Let me get my glasses, Chris. You know I can't see without my glasses. I need glasses. Let me see. Oh, here we are, right here. That's where we are.
No, 21st.
You're right. That's it. Give me 5, man. That's right.
Where's our person coming in here?
So does the immune system play a role? Maybe. There is a small group of people like my child who have improved when treated with immunomodulatory therapies such as intravenous immunoglobulin and certain antibiotics when psychiatric medications were not effective. We don't yet know who this approach may help in the future. The foundation has funded a study to look at immune function in Phelan-McDermid. And I just want to mention this study includes patients over age 10 who have SHANK3 affected in their genetic difference and involves questionnaires in English. So if you're interested and speak English, you can reach out to the email on this slide to learn more. Is there anything we can do to prevent these problems? Well, in consultation with your medical team and other providers, consider how best to buffer stress at transitions by maintaining routines and psychosocial connections. Follow the recommendations about medications to avoid. Keep constipation well controlled. Keep the mouth clean to avoid chronic inflammation. Maintain a healthy diet and make sure that micronutrients like iron and vitamins such as the B vitamins and D are actually being absorbed. And if your doctor agrees, consider supplementation with probiotics and with antioxidants. There are medications to avoid, and we have both research and accumulated case-based evidence to be very cautious about antidepressants and antipsychotic medications. Although we want people to be very cautious, this doesn't mean that antipsychotics should never be used in Phelan-McDermid. Indeed, some need them and tolerate them and benefit from them, particularly for core psychotic symptoms, but they should be used with caution and close observation. And aside from the psychotic symptoms, other medications may be more effective and better tolerated. Figuring out a treatment regimen for psychiatric illness is a matter of cautious trial and error. Individuals with Phelan-McDermid differ from each other in their response. There is no one-size-fits-all approach. Basically, start with very low doses, increase slowly, use anticonvulsants or lithium for mood stabilization, avoid antidepressants, save antipsychotics for actual psychotic symptoms, If the onset is abrupt, you could consider a neuroimmunology consult, and we recommend following the guidelines from the neuropsychiatric consultation group. There are resources for our families, notably the consultation group, which has developed treatment guidelines, which are recently being revised. And in summary, a minority of people with Phelan-McDermid do develop severe psychiatric illness in their teens and 20s. From our observation, it more often resembles bipolar disorder than schizophrenia because it has distinct episodes with periods of return to baseline in between the episodes. These problems are more commonly diagnosed among those with small deletions or SHANK3 variants, but can happen in those with larger deletions as well. People can have unexpected or intense adverse reactions to certain meds, including catatonia. Psychiatric illness can be followed by loss of skills, with those skills regained in about half the cases. And the PMS Foundation in the US has supported and built resources to assist families in coping and accessing treatment resources. So I'll close with thanks again to the foundation, to our researchers, to the clinical experts, and to the families. And I look forward to taking questions.